All right, so we're now into the second part of this lecture discussing both public and private health insurance in the U.S. And so we're focusing primarily on the public side, namely in the way of Medicare and Medicaid and how those programs operate. And so let's go ahead and dive right in to thinking about Medicare. And so if someone were to ask you, what's the difference between Medicare and Medicaid, I think you could point out right off the bat that Medicare we know is social insurance and Medicaid is public assistance. So all the things that we've noted up to this point about distinctions between social insurance and public assistance will apply here in the context of our health insurance programs. And so when we think about Medicare and how one attains eligibility for Medicare, recall that when we talked about Social Security, remember that that FICA tax, that 6.2% FICA tax for Social Security, FICA also mandates a tax collected for Medicare purposes. It's under the same piece of legislation, and so if you've made your required contributions over your lifetime, as one would be required to under Social Security, in the same way that you make your contributions under Social Security, you make your same contributions, or not the same, but a 1.45% tax that gets taken out. If you've made those required contributions for at least 10 years, you also attain eligibility for Medicare in addition to Social Security. And so categorically speaking, there's three different pathways into Medicare eligibility. One is on the basis of age, and so if you've attained the age of 65, note that I'm not saying 66. 66 is the full retirement age for Social Security. So if you've attained age 66 for Social Security and then 65 for Medicare, that would give you one pathway into Medicare eligibility. A second is if you've been receiving disability benefits under the Social Security program for at least 2 years, that's another pathway into Medicare eligibility. And then the third pathway, regardless of age, is if you have end-stage renal disease, that is kidney failure, that's your third pathway into Medicare eligibility. All right, we're looking here at the benefit structure for Medicare, and Medicare is broken up into four major parts. It's parts A through D, and so I've excluded any discussion of Part C. Part C is essentially your Medigap plan, which is basically private health insurance companies coming together on the Medicare website, offering you assistance or health insurance coverage for any gaps that you might experience in your coverage from parts A, B, and D. And so that's the essence of Part C. So aside from Part C, these are the major benefits that you would receive under the Medicare program, parts A, B, and D. And so Part A will cover your overnight hospital stays and some transitional nursing home care. So notice I didn't say long-term care in a nursing facility. That's covered under Medicaid, but under Medicare Part A, you just receive some transitional or limited skilled nursing care and also hospice benefits as well. And so sometimes people are curious about what they would have to pay, what they have to pay under each of these different components. And so for Part A, actually for all of these components, if you're thinking in the way of premiums, deductibles, and co-pays or co-insurance amounts, for Part A, your premium, basically you pay nothing, right? You've made the required contributions over your lifetime, and so Medicare Part A basically says that you don't have to make any regular payments in order to receive Part A benefits, your overnight hospital stays to be covered. But you do have to pay deductibles, right? You have to pay what amounts to essentially your first night stay at a hospital or what that average cost would be from year to year. And so for 2015, that amount is $1,260. And so you're in essence paying the first night stay, and then Medicare, excuse me, and then Medicare Part A kicks in from days 2 through 60, covers all of those expenses, and then from days 61 through 90, there is a copay. There's a copay, we're saying in the rate of 25%. You pay 25% of the cost from days 61 through 90, whatever that amounts to, and then from days 91 onwards, you pay at a rate of 50% of that cost. Now note that this is for each benefit period, so this is referring to each time you stay at a hospital. That's Part A, and so Part B is referring to your doctor services or doctor visits and your outpatient services. And so if we're thinking once again about what you would end up paying for the different services, there is a premium here. So your regular contributions that you've made over your lifetime for Part A does not give you automatic coverage under Part B or Part D for that matter. You have to pay extra. You pay a premium, $104.90 for 2015. That's a monthly premium. You're going to pay that on a monthly basis. Most people, most older adults who have Part A coverage also opt into Part B because compared to the options in the private market, $104 a month for doctor services is quite reasonable. And then in the way of deductibles and copays, you have a $147 deductible. You pay the first $147 in the way of doctor services, and anything in excess of $147. Medicare kicks in, will pay 80%, making your copay 20%, of course. And then you have the Part D component, which covers your prescription drug benefits. This was the most recent addition. This was part of the younger President Bush, his Medicare Modernization Act that was implemented in 2006. And so that's to cover your drug costs. Now, speaking a little more about Medicare Part D, once again, if we're thinking about what you would end up paying, the monthly premium depends on the type of plan that you purchase. Once again, note that you don't get Part D automatically, unlike Part A, and so you have to go out and actually purchase one of these plans. And so that premium that you'll end up paying on a month-to-month basis, on average, is about $33 out of pocket. And then notice that you have a $320 deductible. That's a yearly deductible, and so you can think about how much you might be spending in the way of prescription drugs on an annual basis. You're going to pay the first $320, at which point Medicare Part D kicks in and will cover 95% of costs. But one of the big policy issues that's sort of plagued this program historically, since 2006 that is this donut hole, what's referred to as a donut hole, or basically a gap in coverage. And so if you have prescription drug costs exceeding $2,960 a year, you're going to have to pay 45%. Your copay is 45% on brand name drugs and then 65% for generic drugs. And so that's been labeled a donut hole, and that's been closed, or it'll eventually be dissipated, in other words, because of the Affordable Care Act of 2010. So by 2020, you're not going to see that extent of copay percentages. That'll be down to 25%, a maximum 25% copay on prescription drug costs exceeding $2,960 by 2020. Now, just a quick note about catastrophic coverage. If you're spending more than $4,700 per year on your prescription drugs, which we label as catastrophic needs, those are covered. 95% of those costs are covered by Medicare Part D, making your copay, of course, 5%. All right, if we're looking a little more globally at Medicare, at the Medicare program and what's been changed as a result of the Affordable Care Act, note that in the early years of the Affordable Care Act, what we attempted to do as a policy matter was to cover people between the ages of 62 and 65. And those ages are very specific because your Social Security kicks in at 62, but you're not going to be eligible for Medicare under 65. And so what this legislation accomplished was this temporary reinsurance program that would cover that gap, but we've since run out of funds. This is no longer in existence because we ran out of funds to operate this program. But one of the major changes under the Affordable Care Act is that we implemented a Medicare tax hike beginning in 2013 to cover the cost of this new program. And so most of us don't notice this tax hike, but for those individuals earning in excess of $200,000 a year, you pay an additional 0.9% on your Medicare tax. Your 1.45%, tack on an additional almost 1% if you're making more than $200,000 as an individual, and if you're making more than $250,000 as a married couple. That's one of the major changes. And of course, we just pointed out that one of the accomplishments of the Affordable Care Act was to close that donut hole, or that gap in coverage that we saw under the Medicare Part D component. Now we're moving to Medicaid, the public assistance sibling to the Medicare program. And so we note that Medicaid is public assistance, so all the things that we noted before about public assistance applies here. This is funded by our general revenues, by general revenue taxing. And so historically, what we've had is sort of a cost sharing between the federal and the state governments to finance Medicaid, where the federal government would support anywhere between 50 to 80% of costs in the way of administering this program, depending on state wealth. So the more wealthy states would receive lower contributions, so lower meaning closer to 50%, and the poorer states, in the way of average income, would receive a greater percentage in the way of contributions, closer to 80%. That's the way the Medicaid program was historically funded. And so if we're thinking in the way of how one might attain eligibility for Medicaid, we noted that it's public assistance, so you must be poor. Now, one of the major policy issues prior to implementation of ACA or the Affordable Care Act was that these rules were completely fragmented from one state to the next. So we didn't have any uniform rules across the different states, and so there was a lot of confusion about how one attains eligibility. The Affordable Care Act, when it was initially passed, set a minimum floor of 133% of poverty as the eligibility threshold across all the different states, but with lawsuits across the U.S., states were then given the option of whether or not to provide coverage to the working age population. And so we still have a great degree of fragmentation despite the Affordable Care Act. One example, I'll just point out our state, one example of this fragmentation. Look at the rules here in terms of income eligibility. If you're a family with a child, right, if you have kids under 19, we have an income threshold of 142% of poverty. So anyone with income, with household income less than 142% will qualify. But then look at the next category over. If you're a pregnant woman, that threshold is 208%. And then for all adults, it's 133%. And so not all states offer coverage for adults, for the working age population. So this is just one example of the fragmentation that you see in the income eligibility guidelines from state to state, or even within a state across different categories of potential beneficiaries. Now, in this next section here, I'm just pointing out this little discrepancy between the composition of enrollees and what we actually spend. Notice here that most people who receive Medicaid, if we're looking at different age categories, certainly children, kids make up 50% of all enrollees, or approximately 50% of all enrollees. But if we're thinking about how much we actually spend on the different types of beneficiaries, certainly seniors and persons with disabilities, the average cost per capita or per person is much higher. So per person, if we're talking about persons with disabilities, that's exceeding $10,000, and for seniors exceeding $12,000, whereas we're only spending about $1,300 per child. And so that's just to point out that while older adults make up only about, or persons with disabilities and older adults, while they only make up about 25% of enrollees, they actually account for about 75% of the cost of administering the Medicaid program. Now, if we're looking at the benefits side and what benefits are offered under Medicaid, again, we have fragmentation from state to state. We can't really pin down a general rule that applies to all states. States may pick and choose from among these optional services like dental and eyeglass and such, and prescription drug coverage. But there are some core mandated services that all states must offer. So if we harken back to the Medicare structure, it looks very much like that structure. So all states, under their state Medicaid plans, must provide overnight hospital stays, must provide doctor services. But one big ticket item here in the way of cost is, of course, nursing home care. All states must offer nursing home care to persons over age 21, and so that's really accounting for the large proportion of cost. And then pregnancy services must be offered by all the states. All right, so if we're thinking about some of the major changes under the Affordable Care Act, certainly the intent was to provide some sort of uniform rules for eligibility and benefits offered from state to state, but we've scaled back to a large degree in the last couple of years due to these lawsuits. And so states now have the option to expand Medicaid coverage for the working age population, which was a huge gap, as I pointed out in the first part of this lecture. And so only about half the states have expanded their Medicaid programs to cover the working age population. And we have a different income guidelines from state to state, which really didn't do much in the way of effectuating the purposes of the Affordable Care Act. Now here's a quick note on a program called CHIP, which stands for the Children's Health Insurance Program. This is intended to be a supplement to our state Medicaid programs. And so when states have enough revenue, when they're generating enough revenue to operate this program, the supplemental program, a typical case of how this program would operate is to offer coverage, to offer Medicaid coverage up to a certain percentage of poverty, and then those exceeding that threshold, if the states have revenue left over, they would provide additional services. for those families as well. And so if we're taking Illinois as an example, Illinois, of course, offers Medicaid coverage to families with kids up to 142% of poverty, and then those exceeding 142% of poverty, up to, for Illinois, it's 313% of poverty. So families with kids with income up to 313% of poverty will become eligible, are eligible for the Children's Health Insurance Program. It's a temporary benefit for 12 months. All right, so we're transitioning here into discussing private health insurance. So this is not a class in the private market. It's not an economics class, but I just want to note sort of the big picture in the way of some of the changes that we've made in the private sector. And so I want to note just the philosophy by which the government intervened. We had a system, we had a private system in place where there was a lot of choice in which plans you could go out and purchase if you wanted. But the way that economists view the private insurance market, what we saw previously before the Affordable Care Act, we were starting to see some basic assumptions of an efficiently working market not being met. And so when we think about things like a perfectly competitive market or perfect information that are supposed to make up a perfectly efficient or an efficient market, we weren't seeing those things necessarily. And so essentially what we're saying is that the increasing costs or the exorbitant costs that we're seeing in the way of the private health insurance plans were due to these private market failures, namely the lack of perfect information, the lack of information. And so in response to what we were seeing in the way of market breakdowns, the economist has suggested that we sort of not create a socialized system necessarily. It wasn't completely socialized. That's not what we were going for, but sort of a managed competition framework is what it was called. So we were taking this private market and intervening to a moderate degree, and so that gave birth to the health insurance marketplace essentially, or the exchanges, where you can basically do one-stop shopping for your private health insurance plans. So a little bit of a long-winded way to say that now we have these marketplaces where you can go and where it's intended to be transparent. You can look up all the different plans being offered by different health insurance companies. You can basically shop for the plan that's right for you. And so one of the big issues that's pointed out is that if you don't have coverage, right? If you don't have coverage, you're going to be penalized. There's something called an individual responsibility payment that's assessed through the tax code. And so this is, of course, philosophically speaking, to address this issue of adverse selection, making sure that everyone is covered such that we contain costs on a philosophical level. And so the basic penalty for 2015, if you're not covered, if you don't have some sort of insurance coverage, you're going to be penalized at the amount of $325 per adult, or $162.50 per child, or 2% of your household income exceeding certain thresholds, whichever is higher. And so you can see how these penalties will escalate over time. So by next year, if you're not covered, if you don't have some form of health insurance coverage, whether it be public or private, then you're going to be penalized $695, or 2.5% of household income exceeding certain thresholds for next year. Right, and so if we're thinking about your options, let's say you're making enough money such that you don't qualify for Medicaid, right? The Medicaid program would be the program of last resort, or maybe your state doesn't even offer Medicaid, then you're going to need to go out and shop for a private health insurance plan. And so these are your basic options. You have everything from bronze coverage, bronze, silver, gold, platinum. Basically, those different types of plans are referring to not necessarily the quality or the type of benefits offered. All of these plans will offer the same core 10 benefits, and you can look up at the website, the federal government website, healthinsurance.gov, what those 10 essential benefits are. But essentially, you're just paying for, you're saying how much you want to pay in the way of out-of-pocket costs. And so for bronze coverage, you're going to end up paying about 40% of all the costs out of pocket. And your platinum plan, you're going to end up paying about 10% of costs. And so the basic calculation on the consumer's part is, do you want to pay more upfront, or do you want to pay more later if you need coverage? And so that's what you're calculating essentially when you're thinking about which plan to to select. And so note that there are certain costs or certain caps on how much you'll end up spending out of pocket, and those amounts are listed here, $6,600. So one of the purposes of this legislation was to make sure that there was a cap on how much people were spending out of pocket, and so we've implemented those caps. $6,600 for an individual, $13,200 for a family plan out of pocket per year. So that's taking into account your premiums, your deductibles, and co-pays. That's the maximum that anyone would end up paying based on one of these plans. All right, and so being a social welfare class, certainly we want to assess, we want to compare the low-income worker to the high-income worker once again in the way of tax treatment. And so I just offer up a quick note here that the way that the system's set up is much more favorable, of course, for the higher income worker. And so my reasoning here is that if you think about the federal tax structure, right, the federal tax, and the fact that all of these health insurance benefits, your private health insurance benefits, whether it's employment-based or purchased directly from the health insurance marketplace, there's no federal tax on your health insurance benefits. And so the fact that those plans escape federal income tax liability, that's much more favorable for the higher income worker who ends up paying higher rates typically, higher marginal tax rates, as opposed to the lower income worker who's going to pay at lower rates. And so the fact that these plans are escaping tax liability is much more favorable for the higher income worker who pays at higher rates. All right, so that wraps up the second part of this lecture, and then we'll go ahead and transition into a discussion about the tension or the balancing between cost and quality in the way of health expenditures.